Welcome to the PHSNC Clinical Documentation Training. This training is produced by Fila Health Systems of North Carolina, PHSNC, as a formal internal staff development module for all clinical and direct service team members. The title of this training is The Golden Thread of Therapy: Comprehensive Clinical Assessments, Person-Centered Plans, Daily Documentation, and Helping Clients Live Their Dreams Every Day. Take a moment to settle in. Over the next hour, we are going to walk through one of the most important foundations of quality behavioral health care, and that foundation is documentation. Documentation is not just paperwork. It is not a box to check at the end of a long day. Documentation is the clinical story of your client. It is the record that says, this person came to us, this is what was happening in their life, this is what we assessed, this is what we planned together, and this is the work we did to help them move forward. Strong documentation is how we honor that mission. It is how we show that our work was intentional, that it was connected to real assessed need, and that it was delivered with purpose and care. In this training, we will explore what we call the golden thread, the unbroken line that connects your assessment, your treatment plan, and your daily notes into one cohesive clinical story. Whether you are a therapist, a qualified professional, a peer support specialist, a supervisor, or any other member of our care team, this training is for you. Let us begin. Section 2, Learning Objectives. Before we dive into the content, let us take a moment to review what you will learn in this training. These are your learning objectives, the specific things you should be able to do and understand by the time we are finished today. Objective 1. You will be able to define the golden thread in therapy and behavioral health documentation and explain how it connects all parts of the clinical record. Objective 2. You will be able to explain why documentation matters, not just for compliance, but clinically, ethically, operationally, and financially. Objective 3. You will understand the purpose and components of the Comprehensive Clinical Assessment, or CCA, and why it serves as the starting point of every clinical story. Objective 4. You will understand the purpose and structure of the Person-Centered Plan, or PCP, and how it translates assessment findings into a meaningful treatment roadmap. Objective 5. You will be able to write stronger daily service documentation, notes that are specific, connected to the plan, and clearly reflect the clinical work being done. Objective 6. You will be able to explain how the CCA, the PCP, and daily notes work together as one connected clinical story. Objective 7. You will be able to recognize common documentation mistakes and understand how to avoid them. Objective 8. You will be able to use documentation as a tool for person-centered care, documentation that reflects movement, dignity, purpose, and progress toward what clients actually want for their lives. Keep these objectives in mind as we move through the training. Each section is designed to build on the last, and by the end, you will have a solid framework you can bring back to your work every single day. Section 3, What is the golden thread? Let us talk about one of the most important concepts in clinical documentation, the golden thread. The golden thread is the consistent, unbroken connection that runs through every piece of a client's clinical record. It is what links the presenting problem to the assessment to the treatment plan to the interventions, and the interventions to the client's progress and outcomes. Think of it this way. When someone picks up a client's chart, whether that is a supervisor, a quality reviewer, an auditor, or a new provider who has just joined the team, they should be able to read through the record and immediately understand the full clinical story. They should be able to answer 4 fundamental questions. Why is this client receiving services? What clinical needs have been identified? What interventions were used to address those needs? And how is this work supporting the client's goals and movement toward a better life? If a record cannot answer those 4 questions clearly, the golden thread has been broken. Here is how the golden thread flows in behavioral health care. It begins with the comprehensive clinical assessment. The CCA is where we gather the full clinical picture, the presenting concerns, the symptoms, the history, the strengths, the barriers, and the functional impairments that make treatment necessary. From the CCA, we move to the person-centered plan. The PCP takes what we learned in the assessment and turns it into a roadmap. It identifies the goals, the objectives, the interventions, and the expected outcomes. The PCP says, here is where the client is, and here is where we are going together. From the PCP, we move to daily service documentation. Every note, every session, every contact, it should directly reflect the work being done in the plan. The note should show which goal was addressed, what intervention was used, how the client responded, and what progress or barriers were observed. And then, over time, the documentation should show movement, progress, change, growth. That is what the golden thread looks like in action. Here is a reflection question for you. Pause and consider. Does your documentation clearly show the golden thread? If someone reviewed your client's chart today, could they follow the story from beginning to end and understand exactly what is happening and why? Hold that question as we move forward. We will come back to it throughout this training. Section 4. Why documentation matters. Now that we understand the golden thread concept, let us talk about why documentation matters so deeply, not just for paperwork, but for everything that defines quality care. We're going to look at this from 4 different angles. Why documentation matters for the client, why it matters for staff, why it matters for the agency, and why it matters for compliance, medical necessity, billing integrity, and audit readiness. Why documentation matters for the client. First and foremost, documentation exists to serve the client. The clinical record is the ongoing story of a person's treatment journey. When documentation is thorough, specific, and well-connected, it ensures continuity of care. If a client transitions to a new provider, the next clinician can pick up where the last one left off. They do not have to start from scratch. The client does not have to retell their entire story. Strong documentation protects the client's progress and honors their experience. Documentation also gives voice to the client's goals. When we write notes that reflect what the client actually wants, not just what the provider observed, we are centering the person at the heart of their own treatment. Why documentation matters for staff. Documentation protects you. When you document what you did, why you did it, and how the client responded, you have a clear professional record of your clinical decision-making. If questions arise later about the services provided, your documentation is your evidence. Good documentation also helps you be a better clinician. When you take the time to write thoughtfully about a session, what was addressed, what happened, and what it means for the client's trajectory, you are reflecting on your own practice. That reflection makes you sharper, more intentional, and more effective over time. Why documentation matters for the agency. PHSNC, like all behavioral health organizations, is accountable to licensing boards, accrediting bodies, payers, and regulatory agencies. Documentation is the primary way we demonstrate that services were delivered as promised, that they were clinically appropriate, and that they met the standards required of us. When an auditor or reviewer comes to assess our records, they are looking for evidence. They want to see the golden thread. They want to see that every service billed was medically necessary, that every goal was connected to an assessed need, and that every note reflects real clinical work. If the documentation does not show that, the agency is at risk, regardless of how good the actual care was. This brings us to a critical truth. If it is not documented, it did not happen. You may have done exceptional work with a client, but if that work is not captured clearly in the record, it cannot be verified, it cannot be billed, and it cannot support the continuity of treatment. Why documentation matters for compliance, medical necessity, billing integrity, and audit readiness. Medical necessity is the foundation of behavioral health billing. For a service to be billable, it must meet the criteria for medical necessity, meaning there must be a documented clinical reason why the service was needed. That reason has to be clear in the CCA, reflected in the PCP, and demonstrated in every service note. When documentation is vague, disconnected, or missing key elements, it creates gaps in the record that cannot support medical necessity. That puts billing at risk. And when billing is at risk, the financial sustainability of the agency is at risk, which ultimately affects the clients we serve. On-screen reminder: documentation is part of care. Documentation tells the clinical story. Documentation supports accountability. Documentation protects the client, the staff, and the agency. Let us carry that understanding forward as we look more closely at the tools we use to build that story, starting with the comprehensive clinical assessment. Section 5. Understanding the comprehensive clinical assessment. The Comprehensive Clinical Assessment, or CCA, is where every client's clinical story begins. It is the foundation upon which everything else is built. Without a strong CCA, there is no solid ground for the treatment plan. Without a strong treatment plan, there is no clear direction for daily services. And without that direction, the golden thread does not exist. So what exactly is the CCA and what should it accomplish? The CCA is a thorough, structured assessment of a client's behavioral health needs. It is designed to capture a complete clinical picture at a specific point in time. A strong CCA should identify the following: the presenting concerns. What is bringing the client to treatment right now? What symptoms are they experiencing? How long have those symptoms been present, and how severe are they? The client's behavioral health history. Have they received services before? What diagnoses have been identified? What treatments have been tried, and what has worked or not worked? Trauma history and current stressors. What adverse experiences has the client had? Are there active stressors in their life? Family conflict, housing instability, grief, legal involvement, unemployment that are contributing to their current presentation. Strengths and supports. What is working for this client? Who is in their corner? What internal strengths, coping skills, or community supports do they have that can be built upon? Barriers to treatment and recovery. What is getting in the way? Transportation, childcare, work schedule, stigma, ambivalence, cognitive limitations. All of these belong in the CCA if they are relevant. Functional impairments. How are the client's symptoms affecting their daily life? Their ability to work, go to school, maintain relationships, care for themselves, or live independently. Functional impairment is critical for establishing medical necessity. Clinical recommendations. Based on all of the above, what level of care is clinically appropriate? What services are recommended and why? Here is a practical example of how a strong CCA drives better care. Imagine a client named Marcus. He is a 32-year-old man presenting with symptoms of depression following the loss of his mother 6 months ago. He reports difficulty sleeping, low motivation, social withdrawal, and trouble concentrating at work. A weak CCA might say, client presents with depressive symptoms, recommend therapy. A strong CCA says, client presents with major depressive episode following bereavement. He reports persistent low mood, hypersomnia, anhedonia, and difficulty concentrating over the past 6 months. These symptoms have impaired his occupational functioning. He has received 2 written warnings at work and have led to social isolation. He reports no prior mental health treatment and no suicidal ideation. Protective factors include stable housing, supportive sister, and strong motivation to improve. He identifies his goal as returning to a life that feels meaningful. Individual therapy is recommended to address grief processing, depressive symptom management, and occupational stabilization. Do you see the difference? The second version gives the next provider, the treatment team, and any reviewer a clear picture of who Marcus is, what he is dealing with, how it is affecting his life, and what treatment is warranted. That is the starting point of the golden thread. Let us also talk about common CCA problems, because these are among the most frequent documentation errors we see in behavioral health settings. Vague language is one of the most common. Saying a client is having difficulty coping is not enough. With what? Since when? How is it affecting their functioning? Be specific. Limited functional detail is another major issue. Stating that a client has depression without explaining how depression is affecting their daily life does not establish medical necessity. We need to see the impact, not just the diagnosis. unclear treatment recommendations. If the CCA does not clearly articulate why this level of care is appropriate, it leaves a gap in the record that reviewers will flag. And weak connection to service need. The CCA should make it obvious why the services being requested are necessary. If someone reads the CCA and cannot understand why the client is receiving the services on the plan, the thread is broken right at the start. Take a moment to reflect. Think about a CCA you have recently completed or reviewed. Did it clearly answer, what is happening with this client? How is it affecting their daily functioning? Why is treatment needed? And what strengths can we build upon? That is the standard we are working toward at PHSNC. Section 6. Understanding the person-centered plan. Now that we have a strong CCA, a thorough clinical picture of who the client is, what they are facing, and what they need, we move to the next critical step, the person-centered plan, or PCP. If the CCA is the starting point of the clinical story, the PCP is the roadmap. It takes everything identified in the assessment and transforms it into action. It says, here's where the client is, and here's the path we will take together to move toward where they want to be. Let us break down the key components of a strong PCP. The problem statement. Every goal on the PCP should begin with a clearly identified problem that was established in the CCA. If you cannot trace a PCP goal back to a specific finding in the assessment, that is a golden thread break. The problem statement should be specific and clinically grounded. Person-centered goals. Here is where the PCP truly earns its name. The goals on the plan should reflect what the client actually wants for their life, not just what the provider wants to document. At PHSNC, we believe that treatment should help clients move closer to real-life goals. Goals like improve family relationships, return to school consistently, maintain sobriety, reduce emotional outbursts, improve coping strategies, increase independence, and strengthen recovery supports. These are life-oriented goals. They connect treatment to living. Measurable objectives. Goals tell us where we are going. Objectives tell us how we will know we are getting there. A strong objective is specific, observable, and time-limited. It tells the reviewer, this is what success looks like, and this is when we expect to see it. Interventions. The PCP should clearly describe the clinical interventions that will be used to help the client achieve each objective. Interventions are not just service types. They describe what the provider will actually do. Cognitive behavioral techniques, motivational interviewing, psychoeducation, skill building, family systems work. These are examples of interventions. Saying the provider will meet with the client weekly is a schedule, not an intervention. Target outcomes. What does success look like at the end of the treatment period? The PCP should paint a picture of where the client is expected to be when treatment goals are achieved. Let us look at a full example that brings all of these components together. Assessed problem from the CCA. Client presents with a major depressive episode following bereavement, with associated functional impairment in occupational and social domains. PCP goal. Client will reduce depressive symptoms and improve daily functioning to support occupational stability and social reconnection. Measurable objective. Client will report a reduction in depressive symptoms from a PHQ-9 score of 18 to a score of 9 or below within 90 days, as evidenced by self-report and clinician observation. Intervention. Clinician will utilize cognitive behavioral therapy techniques, including behavioral activation and cognitive restructuring, to address grief-related depression and maladaptive thought patterns. Psychoeducation will be provided on the connection between mood, behavior, and functioning. Do you see how this flows? The assessed need drives the goal. The goal is specific and meaningful to the client's life. The objective is measurable, and the intervention is clinically specific. It tells the reader exactly what the clinician is doing and why. Now let us look at common PCP mistakes, because these are just as important to understand. Vague goals. A goal that says the client will improve mental health does not tell us anything. Improve in what way? By what measure? In what time frame? Vague goals cannot be tracked or evaluated. Non-measurable objectives. If we cannot tell whether progress has been made, the objective is not doing its job. Every objective needs a measurable indicator. Repetitive interventions. Writing the same intervention in the same words for every goal is a red flag. Interventions should be tailored to the specific goal and need they are addressing. Goals not linked to assessed needs. If a goal appears on the PCP without a clear connection to the CCA, it raises the question, why is this goal here? Every goal must be rooted in the assessment. Plans that are not person-centered. If the plan reads like a clinical checklist that could apply to any client, rather than a document that reflects this specific person's goals and values, it is not truly person-centered. The client's voice should be evident in the plan. Here is a mid-training recap. So far, we have established the concept of the golden thread. We have learned why documentation matters for clients, staff, agencies, and compliance. We have explored the CCA as the foundation of the clinical story, and we have walked through the components of a strong, person-centered treatment plan. In the next sections, we are going to look at how daily service documentation builds on everything we have covered, and how it keeps the golden thread strong day after day. Section 7, Daily Service Documentation. Welcome to one of the most practical sections of this training, Daily Service Documentation. This is where the rubber meets the road. The CCA sets the foundation, the PCP builds the roadmap, but it is the daily service note that proves the work was done. Every time you provide a service and document it, you are contributing another chapter to the client's clinical story. You are showing the reviewer, the supervisor, the auditor, and most importantly, the next provider. This is what we did, this is why we did it, and this is what happened. A strong daily service note should answer 5 essential questions. What need or goal was addressed in this service? Every note should be anchored to a specific problem or goal from the PCP. If the note cannot be traced back to the plan, the golden thread is broken. What intervention was provided? This is not the service type. It is what you actually did. Did you use motivational interviewing to explore ambivalence about medication? Did you teach a breathing technique to manage anxiety? Did you facilitate a role play to practice assertive communication? Be specific about the clinical technique or approach you used. How did the client respond? The client's response is critical documentation. Did they engage actively? Did they express resistance? Were they tearful, guarded, hopeful, overwhelmed? How the client responded tells us whether the intervention landed, and it helps us plan next steps. What progress or barriers were observed? Is the client moving closer to their goal? Are there new obstacles, new stressors, medication concerns, family disruptions, safety issues that need to be addressed? The note should reflect the client's trajectory. Why does the service remain relevant? This question is about medical necessity. If a reviewer reads this note, do they understand why this client still needs this service? The note should make the ongoing need clear. Here is a simple framework you can use to structure every note. We call it the 4-part documentation framework. Step 1. Need or goal addressed. State which goal or objective from the PCP was the focus of this service. Step 2. Intervention. Describe the specific clinical intervention or technique used during this service. Step 3. Client response. Document how the client responded behaviorally, emotionally, verbally. Step 4. Progress and plan. Describe the client's current progress, note any barriers, and indicate the plan for the next service. Another way to think about this is the PIE model: problem, intervention, effectiveness. Start with the problem being addressed, describe the intervention, and describe how effective it was. Whichever framework you use, the key principles remain the same. Notes should be specific, they should be timely, documented as close to the service as possible, and they should be linked to the PCP. Every note should connect back to the plan. Let me be clear about what daily notes should not look like. A note that says, met with client, discussed her week, client was doing okay, will continue treatment. That note does not meet the standard. It does not identify a goal, it does not describe an intervention, it does not capture the client's response, and it gives absolutely no evidence that this service was medically necessary or clinically valuable. We are going to look at exactly this kind of note comparison in the next section, with real examples you can learn from. Let's keep moving. Section 8, Documentation Examples. In this section, we are going to look at real-world documentation examples across 4 different service types. For each one, we will examine a strong note and walk through why it works. Then we will look at a weak note and break down what is missing and how to fix it. Let us start with individual therapy. Here is a strong individual therapy note. Goal addressed: reduce depressive symptoms and improve daily functioning, as outlined in the PCP Goal 1. Intervention: clinician utilized cognitive behavioral therapy techniques to address the client's pattern of negative automatic thoughts related to grief and self-worth. The client identified 3 recurring cognitive distortions: catastrophizing, personalization, and all-or-nothing thinking, and engaged in thought-challenging exercises to reframe each distortion with more balanced perspectives. Psychoeducation was provided regarding the relationship between thoughts, emotions, and behavior. Client response: the client was engaged and reflective throughout the session. He expressed initial skepticism about the effectiveness of thought challenging, but demonstrated improved insight by the end of the session, stating, "I realize I have been blaming myself for things that were not in my control." He completed the thought record worksheet independently and agreed to continue practicing between sessions. Progress and plan. Client is demonstrating early progress in identifying maladaptive thought patterns. No safety concerns noted. Plan is to continue cognitive restructuring in next session and introduce behavioral activation strategies to address social withdrawal. Why is this note strong? It identifies the specific PCP goal. It describes a specific clinical intervention, not just therapy, but CBT thought challenging, with specific techniques named. It captures the client's verbal and emotional response, including a direct quote, and it speaks to progress and next steps. This note tells a clinical story. Now let's look at a family therapy example. Goal addressed: improve family communication and reduce conflict in the home environment. Intervention: clinician facilitated a conjoint session with the client and her mother using structural family therapy techniques. The session focused on clarifying roles and boundaries within the family system. The Sater communication model was referenced to help both parties identify and shift from blaming and placating communication patterns toward more assertive and leveled communication. Each family member was given the opportunity to express their perspective without interruption, with the clinician modeling reflective listening. Client response: initial tension was present at the start of the session. The client became tearful when discussing feeling dismissed by her mother. The mother expressed defensiveness initially, but softened when she heard how her responses were experienced by her daughter. Both reported feeling heard by the end of the session and agreed to practice one communication skill before the next session. Progress and plan. Moderate progress observed. Both parties demonstrated willingness to engage in skill practice. Plan to review homework at next session and continue work on boundary setting and conflict de-escalation strategies. Now, a substance use focus session. Goal addressed: maintain sobriety and strengthen recovery supports, as outlined in PCP Goal 3. Intervention: clinician utilized motivational interviewing to explore the client's ambivalence about continued recovery following a recent near-relapse event. Open-ended questions were used to elicit the client's own reasons for maintaining sobriety. The clinician reflected change talk and acknowledged the client's identification of triggers related to social isolation and boredom. A brief relapse prevention plan review was conducted, and the client identified 2 new coping strategies to add to his plan. Client response: the client was forthcoming about the near-relapse event and expressed relief at being able to discuss it without judgment. He identified 3 triggers and 2 new protective factors. He appeared motivated and stated he is committed to his recovery. No active substance use reported at time of session. Progress and plan. Client is demonstrating resilience following a high-risk period. The relapse prevention plan was updated. Plan to connect client with peer support specialist for additional recovery coaching and to review updated plan at next session. Now, a peer support or community support style note. Goal addressed: increase independence and community integration. Intervention: peer support specialist accompanied the client to a community recreation center to support her stated goal of re-engaging with social activities. During transit, the specialist used peer mentorship techniques, sharing their own lived experience with social anxiety and recovery to normalize the client's apprehension. Upon arrival, the specialist supported the client in registering for a weekly art class and introducing herself to the program coordinator. Skills practiced included self-advocacy, introduction, and asking for information. Client response. The client initially expressed reluctance and reported feeling anxious. However, she followed through and successfully registered for the class. She reported feeling proud of herself at the end of the activity and stated, "I did not think I could do that." Progress and plan. Strong progress toward community integration goal. This was the client's first community outing in over 2 months. Plan to process the experience in next peer support session and identify one additional community engagement opportunity. Now let us look at what a weak note looks like and why it fails. Weak note. Met with client, talked about her week, client was okay, will continue treatment. This note fails on every level. It does not identify a goal. It does not describe an intervention. Talking about someone's week is not a clinical intervention. It does not capture the client's response in any meaningful way. It provides no evidence that this service was necessary. And if an auditor reviewed this note, they would have serious concerns about both the quality of care and the billing integrity of this service. Here is the rewritten, strong version of the same session. Goal addressed, reduce anxiety and improve coping strategies. PCP Goal 2. Intervention. Clinician utilized cognitive behavioral techniques to address the client's reported increase in anxiety related to upcoming family court proceedings. Clinician provided psychoeducation on the stress-anxiety cycle and guided the client through a progressive muscle relaxation exercise. The client also identified 2 cognitive distortions, fortune-telling and magnification, and practiced reframing each with more balanced thoughts. Client response. The client was initially tense and tearful when discussing the court proceedings. She engaged willingly with the relaxation exercise and reported a reduction in subjective anxiety from an 8 out of 10 to a 4 out of 10 by the end of the session. She expressed feeling more in control and agreed to practice the relaxation technique daily before the court date. Progress and plan. Client is demonstrating growing capacity to use coping skills under stress. Safety assessed. No concerns noted. Plan to continue anxiety management and add session focused on communication skills for courtroom setting at next appointment. This rewrite tells the whole story. It is the same session, but now it has clinical value, billing support, and a clear connection to the golden thread. Can another provider read your note and understand what happened and why it mattered? If the answer is yes, you are on the right track. Section 9. How the CCA, PCP, and daily notes work together. We have now covered each individual piece of the clinical record: the CCA, the PCP, the daily service note. But the true power of documentation is not in any one piece. It is in how they work together to form one cohesive, connected clinical story. This is the essence of the golden thread. Let us walk through a complete case example to see this in action. Meet Aaliyah. She is a 26-year-old woman who was referred for outpatient behavioral health services following a period of significant personal loss and family conflict. Here's what the CCA tells us about Aaliyah. The CCA documents that Aaliyah presents with symptoms of depression and grief following the death of her father 8 months ago. She reports persistent sadness, low energy, difficulty concentrating, and increasing tension with her mother and siblings around the management of her late father's affairs. She has begun withdrawing from her social network and recently reduced her hours at work due to difficulty concentrating. Aaliyah's strengths include strong verbal communication skills, a small but reliable support network of 2 close friends, and high motivation for treatment. She states her primary goal is to feel like herself again, get back to full-time work, and repair her relationship with her mother. Functionally, she is experiencing impairment in occupational, social, and family domains. Her PHQ-9 score is 16, indicating moderately severe depression. Individual therapy is clinically recommended with a focus on grief processing, depressive symptom reduction, and family relationship repair. Now, here is how that CCA becomes a PCP. The PCP for Alia includes 3 goals, each directly connected to what the CCA identified. Goal 1. Alia will reduce depressive symptoms to improve daily functioning and return to full-time employment. Objective. Alia will report a reduction in PHQ-9 score from 16 to 8 or below within 90 days. Intervention. Clinician will use CBT and grief-focused therapy techniques to process the loss of her father and address associated depressive cognitions. Goal 2. Alia will improve communication and reduce conflict with her mother and family. Objective. Alia will identify and implement 2 conflict resolution strategies within 60 days, as evidenced by self-report and session observation. Intervention. Clinician will use family systems and communication skill building to support Alia in understanding family dynamics and developing assertive, non-confrontational communication strategies. Goal 3. Alia will expand her social support network and reduce isolation. Objective. Alia will initiate contact with at least 1 friend or support person per week for 60 days, as evidenced by self-report and session check-in. Intervention. Behavioral activation strategies will be used to reduce avoidance and support gradual re-engagement with her social network. Do you see the golden thread already forming? Every goal comes directly from the CCA. Every objective is measurable. Every intervention is clinically specific and relevant to the identified need. Now let's look at how a daily service note continues the thread. Session note, week 4 of treatment, individual therapy. Goal addressed, reduce depressive symptoms and process grief, PCP Goal 1. Intervention. Clinician utilized grief-focused CBT to address Alia's avoidance of memories related to her father. Through a guided imagery exercise, Alia was supported in accessing and tolerating a positive memory of time spent with her father without the use of emotional suppression. The session also addressed the cognitive distortion that allowing herself to grieve means she is moving away from her father, which was reframed toward understanding that honoring grief is a form of continued connection. Client response. Alia became tearful during the imagery exercise but remained engaged throughout. She reported that the reframe felt meaningful and stated, "I have been afraid that if I cry about him, it means I have given up on him somehow, but I see it differently now." She expressed a sense of relief at the end of the session. Progress and plan. Alia is demonstrating meaningful early progress in grief processing. PHQ-9 re-administered, score decreased from 16 to 12, indicating early symptom reduction. Safety assessed, no concerns. Plan to continue grief-focused work next session and begin introducing behavioral activation for social re-engagement. Notice what just happened. We can trace this note back to the CCA finding of grief-related depression. We can connect it to PCP Goal 1. We can see the specific intervention used. We can see the client's emotional and verbal response. We have a measurable progress indicator in the PHQ-9 score, and we have a plan for next steps. That is the golden thread in full operation. Over time, as documentation continues to build, session after session, review after review, update after update, the clinical record tells the whole story of Alia's journey. It shows where she started, it shows the work that was done, and it shows the progress she made toward living the life she described when she first walked through the door. Here's the reflection question for this section. Does your documentation tell a story like this? If another provider took over Alia's care tomorrow and read her chart, would they understand exactly where she came from, what has been done, and where she is headed? That is the standard the golden thread holds us to. Section 10, Developing Better PCPs and Better Notes at PHSNC. Everything we have covered so far gives us a strong foundation. But let us move into the practical coaching space. Because knowing what good documentation looks like is one thing, and actually developing the habits to produce it consistently is another. At PHSNC, we want every member of our clinical team to feel empowered to write documentation that is not just compliant, but genuinely reflective of the meaningful work being done with clients every day. Here is a set of coaching questions we want you to carry with you every time you sit down to write a CCA, develop a PCP, or complete a service note. When writing or updating the CCA, ask yourself, what is happening with this client? What symptoms are present? And how long have they been occurring? How are those symptoms affecting this person's daily life, their ability to work, go to school, maintain relationships, care for themselves? Why is treatment needed at this level of care? And what strengths does this client bring that we can build upon? When building the PCP, ask yourself, what did the assessment identify as the primary clinical needs? What does the client want to change or achieve? What is getting in the way of their functioning, their recovery, or their goals? How will progress be measured? What does improvement look like? And what interventions are clinically appropriate for the needs identified? When writing daily service notes, ask yourself, which goal am I addressing today? What specific intervention did I use? Not just the modality, but the actual clinical technique. How did the client respond, both behaviorally and emotionally? What progress did I observe, or what barriers are present? And does my note make it clear why this service was still necessary? These are not complicated questions, but they are the questions that, when answered consistently and honestly in the clinical record, build a golden thread that is strong, coherent, and meaningful. Here's the deeper truth about documentation at PHSNC. Treatment should help clients move closer to real-life goals, not just complete paperwork requirements. Every goal we write, every note we document, should be a step on a path that leads somewhere real for the person we are serving. At PHSNC, documentation should reflect more than compliance. It should reflect movement, purpose, dignity, and progress. When we write a note that says a client identified 2 cognitive distortions and reframed them, that is not just a box checked. That is a person learning to see themselves and their world differently. When we write a note that says a client initiated contact with a friend for the first time in 2 months, that is not just a behavioral activation outcome. That is someone beginning to step back into their life. Documentation, done well, is the professional record of human change, and that is worth getting right. Remember why we are here, helping you live their dreams every day. That is the mission. And your documentation is one of the most powerful tools you have for making that mission real. Section 11, Common Documentation Mistakes. Let us spend a few minutes being direct about the most common documentation mistakes we see in behavioral health settings. These are not criticisms, they are learning opportunities. Every one of us has made at least one of these errors at some point. The goal is to recognize them, understand why they are problematic, and commit to doing better. Documentation mistake number 1, copy and paste documentation. This is one of the most serious documentation errors in behavioral health. When a provider copies a note from a previous session or even a previous week and pastes it into a new note without updating it to reflect what actually happened today, the documentation is inaccurate. It does not reflect the service that was actually provided. It creates legal and billing risk, and in some cases, it can be considered fraud. Every note must reflect what actually happened in that specific service encounter. Documentation mistake number 2, vague notes. Notes that use non-specific, generic language. The client was doing okay, the client is making progress, the session went well. Do not meet clinical documentation standards. They do not demonstrate medical necessity, they do not reflect the clinical work, and they do not support continuity of care. Be specific about what was observed, what was said, what was done, and what it means. Documentation mistake number 3, missing intervention detail. Saying that you met with the client for individual therapy is not enough. What did you do in that session? What clinical technique or approach was used? Why was it used? How does it connect to the goal? The intervention is the heart of the service. It must be clearly described. Documentation mistake number 4, missing client response. The client's response to the intervention is essential documentation. Without it, we have no evidence that the service was interactive, clinically responsive, or individualized. How did the client respond? What did they say? What did they do? Were there any concerns? Documentation mistake number 5, notes not linked to goals. Every service note should be anchored to a specific goal or objective from the PCP. If the note does not reference the plan, the golden thread is broken. Reviewers and auditors will look for this connection. If it is not there, it raises serious questions about the clinical value of the service. Documentation mistake number 6, failing to show medical necessity. Medical necessity is the clinical justification for why a service is needed. If a reviewer cannot understand why the client requires ongoing services based on the documentation, that is a medical necessity failure. The notes should consistently reflect the client's current level of need and the clinical rationale for continued treatment. Documentation mistake number 7, untimely documentation. Notes that are completed days or weeks after a service was provided are a documentation red flag. They are more likely to be inaccurate, they suggest poor professional practice, and they raise questions in audits. Notes should be completed as close to the time of service as possible, ideally on the same day. Documentation mistake number 8. Notes that describe conversation but not clinical work. There is a difference between describing what was talked about and describing what clinical work was done. A note that says the client and provider discussed the client's relationship with her mother is a description of a topic. A note that says the clinician used structural family therapy techniques to help the client identify her role in the family system and explore how boundary violations are contributing to conflict. That is a description of clinical work. Always document the work, not just the conversation. These are the red flags. Learn to recognize them in your own documentation before you sign. The next section gives you a practical tool to help you do exactly that. Section 12, the documentation checklist. Before you sign any piece of documentation, whether it is a CCA, a PCP, or a daily service note, we want you to run through this checklist. These 6 questions are designed to catch gaps before they become problems, and to ensure that every document you produce reflects the standard of care PHSNC is committed to delivering. Documentation checklist question 1. Does this documentation connect to an assessed need? Can you trace what you have written back to something that was identified in the comprehensive clinical assessment? Whether you are writing a treatment goal or a service note, it must be rooted in the clinical picture established at assessment. If you cannot make that connection, ask yourself, does the CCA need to be updated, or is this documentation addressing something that was never properly assessed? Documentation checklist question 2. Does this connect to a PCP goal or objective? Every service provided should be connected to the treatment plan. If you are documenting a session, which goal or objective were you working on? If a reviewer reads this note, will they be able to match it to a specific item on the plan? If the answer is no, revise the note before signing. Documentation checklist question 3. Did I clearly state the intervention I used? Not the service type, the intervention. The specific clinical technique, approach, or strategy employed during this service. Can someone reading this note clearly understand what you did and why? If your intervention section is one vague sentence, strengthen it before signing. Documentation checklist question 4. Did I document the client's response? What happened with the client during this service? How did they engage? What did they say or do? Were there concerns? The client's response is evidence that the service was individualized and interactive. It cannot be missing. Documentation checklist question 5. Did I reflect progress, barriers, or ongoing need? Is the client moving toward their goals? Are there new or ongoing barriers? Does the record clearly reflect why this client still needs services? Medical necessity must be present and evident throughout the record, not just at intake. Documentation checklist question 6. Is this documentation specific, timely, and professional? Specific. Does it describe what actually happened in detail, not in general terms? Timely. Is it being completed at or near the time of service? Professional. Is it written in appropriate clinical language, free of personal bias, slang, or unprofessional characterizations of the client? If you can answer yes to all 6 questions before you sign, you have documentation that is strong, connected, and defensible. Post this checklist somewhere visible. Make it part of your documentation routine. Review it before every signature, because strong documentation is not just a compliance requirement, it is a professional commitment to the clients who trust us with their care. Section 13, Closing Summary and Knowledge Check. Welcome to the final section of this training. Before we close, let us take a moment to recap the key concepts we have covered today, because strong retention begins with review. The golden thread is the unbroken connection that runs through the entire clinical record. From the CCA to the PCP to every daily service note, the thread must remain consistent, clear, and clinically meaningful. If someone can pick up a chart and answer, why is this client receiving services, what needs are being addressed, what interventions are being used, and how is this work supporting the client's goals, the golden thread is intact. The CCA is where the story begins. It captures the full clinical picture, presenting concerns, symptoms, history, trauma, strengths, barriers, functional impairments, and clinical recommendations. A strong CCA is specific, detailed, and establishes clear medical necessity. The PCP is the roadmap. It translates assessment findings into person-centered goals, measurable objectives, specific interventions, and target outcomes. It should reflect what the client actually wants for their life, not just what looks good on a form. Daily service notes are the proof. They show the work. They document the intervention, the client's response, the progress, and the ongoing clinical need. They must be specific, timely, and clearly connected to the plan. Together, these three elements form the clinical story. Taken individually, they are documents. Taken together, they are evidence of intentional, mission-aligned, person-centered care. At PHSNC, we hold this standard because our clients deserve it. Every person we serve has goals, dreams, and a life they are working toward. Our documentation should reflect our commitment to helping them get there. When our documentation is strong, our care is clearer, our treatment is more intentional, and our clients are better supported in living their dreams every day. Now let us move to our knowledge check. This is an opportunity to reinforce what you have learned. Listen to each question, consider your answer, and then we will reveal the correct answer with a brief explanation. Knowledge check question 1. The golden thread in clinical documentation refers to which of the following? A. The requirement to document every session within 24 hours. B. The consistent connection between the assessment, treatment plan, and daily service notes. C. A specific billing code used for behavioral health services. A documentation template required by the state. The correct answer is B. The golden thread refers to the consistent, unbroken connection between the CCA, the PCP, and daily service documentation. It ensures that all parts of the clinical record tell one cohesive, connected story. Knowledge check question 2. Which of the following is a documentation red flag? A note that identifies the specific PCP goal addressed. B. A note that documents the client's response to the intervention. See a note that says, met with client, discussed her week, client was okay, will continue treatment. A note that describes a specific clinical intervention with rationale. The correct answer is C. That note fails to identify a goal, describe a clinical intervention, or capture any meaningful client response. It provides no evidence of medical necessity and does not meet clinical documentation standards. Knowledge check question 3. What is the primary purpose of the comprehensive clinical assessment? To create a billing record for insurance purposes. To establish the full clinical picture that will drive the treatment plan and document medical necessity. C. To document the provider's credentials and licensure. To schedule future appointments with the client. The correct answer is B. The CCA establishes the foundation of the entire clinical record. It identifies presenting needs, functional impairments, strengths, barriers, and clinical recommendations that drive the treatment plan and justify medical necessity. Knowledge check question 4. A person-centered plan goal that says client will improve mental health is an example of which documentation mistake? Copy and paste documentation. A vague, non-measurable goal. Untimely documentation. Missing client response. The correct answer is B. Client will improve mental health is vague and non-measurable. A strong PCP goal must be specific, connected to the assessed need, and supported by a measurable objective. Knowledge check question 5. Which of the following best describes a clinical intervention in a daily service note? Met with client for 1 hour. Discuss the client's family issues. C. Clinician utilized motivational interviewing to explore ambivalence about medication adherence using open-ended questions and reflective listening to elicit change talk. Client will follow up with psychiatrist. The correct answer is C. Answer C describes a specific clinical technique, its purpose, and the methods used. Answers A, B, and D describe logistics, topics, or plans, not clinical interventions. Congratulations! You have completed the PHSNC Clinical Documentation Training, the golden thread of therapy, CCAs, PCPs, daily documentation, and helping clients live their dreams every day. Thank you for your time, your commitment to learning, and your dedication to the people we serve. At PHSNC, we believe that documentation is not just a professional obligation, it is an act of care. Every note you write is a part of someone's story. Every goal you set is a step on their path. Every plan you develop is a commitment to walking that path with them. So document with intention, document with purpose, document with the mission in your heart, helping you live their dreams every day. This training was produced by Fila Health Systems of North Carolina. For questions about clinical documentation standards, please contact your supervisor or clinical leadership team. Thank you.